the GPS inside the pelvis, and it's about predictive anatomy. That is, you need to predict it before it comes. So these are the things that we are going to look at: sacral promontory, fascia, spaces. We know pelvic anatomy is constant, which is the biggest issue. In more than 2000 radical hysterectomies that I have done, I have not seen an uterine artery arising from the external iliac. So if it is a constant anatomy, if the ureter is the most medial structure, what prevents you from learning that? That's the question that I ask, because that's the question which is lying. What lies where, what comes next, and of course anticipating the structure before they come. So let's start. This is how you look into laparoscopy. You can see the two median ligaments. The first thought you should have is the bladder lies between the two median umbilical ligaments. If you do not go medial to the umbilical ligaments, you are not going to enter in the prevascular, sacral, in the cave of Retzius. Similarly, you can see the ureter very nicely. The sacral promontory is this summit. Now this is very important. If you go through Frank Nater, Gray's Anatomy, pelvis is classified separately from the abdomen because its boundaries start at the sacral promontory. Why is it? Because this is the only area where none of the pathologies in the pelvis will reach up to. You can take grade 4 endometriosis, large fibroid, cervical fibroid, you can take whatever it is, but we do not reach the sacral promontory, and there are certain things which happen at sacral promontory. So if you have a difficult case, start your surgery at the level of the sacral promontory, because that's where you have the bifurcation of the common iliac artery. The ureter crosses from the lateral to the medial side and remaining the most medial structure, and therefore if you remain medial to the ureter, be 100% sure that you will never damage any vascular thing. The superior hypogastric plexus lies at that level, and as I said, none of the pathologies reach up to that level. So in case you have a problem, start from the virgin area, which is the sacral promontory. This is what you can see at the level of the sacral promontory. This is the bifurcation of the common iliac. Let's talk about the fascias. There are 4 fascias which are very important: cervicovascical fascia, endopelvic fascia, Wardes fascia, and Denon-Villers fascia. The endopelvic fascia covers the internal iliac muscle and the obturator internus muscles and the levator ani muscle. The most important thing you have to understand, all veins lie under the fascia. So what is the message? That you remain superficial to the fascias, you will never damage the veins. So you can see this is the fascia covering the obturator internus and levator ani muscle, and if you remain above that, nothing will go wrong. The veins lie underneath the fascia. If you understand this concept, then you will never damage the veins which are there. Look at the cervicovascical fascia, look at the Denon-Villers fascia, and look at the presacral or the Wardes fascia. So this is the Denon-Villers fascia. This lies between the two uterosacrals, and this is how you can dissect. This is the cut. You go with the peritoneum. You don't need any kind of energy sources. You can see, because if you are in the right plane, you can see the 2 layers of fascia, and if you are in these 2 layers of fascia, the veins lie below, the rectal veins lie below the fascia, the vaginal veins lie below the fascia. So rectum, and it is done with the concept of fat belongs to the rectum. This was our first publication in 2007, and it was decided that this is a colloquial language, but the editor decided to keep it anyway because it conveys the message correctly. So then comes the cervicovascical fascia. It is this cervicovascical fascia which splits into 2 to get the ureteric tunnel. So if you remember good old days, when you pushed the bladder, there was bleeding because you went between the fascia and the vagina. This is the cervicovascical fascia. The bladder lies anterior to the cervicovascical fascia. Again, the concept is remain below the fat. When you want to dissect the rectum, remain above the fat. When you want to dissect the bladder, remain below the fat. Fat belongs to the organ, and this is the most important thing which is to understand. The cervicovascical fascia is lying and covering the anterior wall of the vagina and divides into 2 on the lateral side to allow the ureter inside. The anterior cervicovascical ligament is the ligament which is called the ureteric tunnel, and there are 2 veins inside that, and this is very important for you to understand. So when you want to dissect this, you can see I'm just showing you how the veins lie below the fascia. So whenever if you go below the fascia, there will be bleeding, but if there is a bleeding, instead of taking care of the vein and pursuing the vein, what you can see, this is the vein below the cervicovascical fascia, and if this is bleeding, don't try to chase the vein, just coagulate the fascia. The vein will automatically get coagulated. This is understanding the anatomy. So if Don't try to coagulate the vein, just coagulate the fascia. This is the bladder dissection. You can see it is very, very simple to do it. This, you start from the lateral side and then you remain superficial to the cervicovesical fascia. Look at the fat, go below the fat, just go below the fat. Fat belongs to the bladder, just go below the fat and just easily you can see that there are no veins, no vascular structures which are seen. What about Walden's fascia? Walden's fascia is the fascia which is in the presacral area. Again, the fat belongs to the rectum. Now remain below the fat when you want to do this. This is the presacral plane which is there, and this is also called as the holy plane of Bill-Heald. This is again, we remain fat, fat and fat are your guide into all these kinds of dissection. So this is the posterior dissection. You can see the fascias. Again, you can see the fascia covering the vein, which is very important to understand this. What about the ligaments? You have three ligaments, the uterosacral, the McEnroth's ligament, and of course lies the anterior vesical ligament. The avascular spaces which lie are important. Why do you have to understand? If you understand any laparoscopic surgery, the adhesions are less because there are no fibroblasts inside the fascia. So if you go in the interfacial plane, there are no adhesions because the anatomy says that there are no fibroblasts, and that is the reason you have to do nice and good. The cancer spreads because the cervicovesical fascia dam the ureter to allow this ureter into the bladder. Because if you don't have this space, this is the weakest space of the vagina from where the tumors go outside, and this is the area. You can go through this article, facial anatomy and its relevance in safe laparoscopy. The significance of the fascias, these are the fascias, always cover the veins. Veins lie underneath the fascias. There are no fibroblasts, and you should always remain in the interfacial plane. And remember, the fat belongs to the organ. What about the other spaces that we are going to look at? There are various spaces. The pararectal space is the most important space. It is divided by the ureter into two. The lateral space, which is called as the Latsko space, and the medial space, which is called as the Okabayashi space. Now there are two approaches. One is a medial approach. You can cut the peritoneum medial to the infundibulopelvic ligament and approach the retroperitoneum from here, or you can do the lateral approach, which is by remaining parallel to the infundibulopelvic ligament. You can see that, and then open this space. This is called as the oncological way of opening the pararectal spaces. Now, the most important space is, of course, the pararectal space. When you want to dissect it, you start on the medial side, cut the peritoneum, go underneath and cut the posterior leaf of the broad ligament. Now, when you see this, that's the ureter. You don't see the internal iliac. Just remain parallel and lateral to the ureter. Just remain parallel and lateral to the ureter. The only structure that will prevent you from going downwards is the uterine artery. That's the artery which is going there. Then you see the superior vesical artery on the top. That's the second branch. Go between the uterine artery and the superior vesicle. Push everything. Just push everything. That opens the paravesical space. These are the two spaces, if a gynecologist wants to learn, very important. Now, if you remain parallel and medial to the ureter, you open the Okabayashi space. Very simple. Parallel and lateral to the ureter will lead you to the Latsko space. Parallel and medial to the ureter will give you the Okabayashi space, which is harboring the hypogastric nerves. Remember the rules of dissection, and it will be very, very easy. What about the dissection in the posterior wall? This is how you should be doing. Fat belongs to the rectum, and fat belongs to the rectum is the dictum. So you can see either you can use a harmonic or you can use scissors. This is the fat. Look at the fat. Don't look anywhere. Just if you go there, wrong plane, just go above the fat, and this will automatically open. Simple visual signs which you have to understand and do it. Fat belongs to the rectum. You can see the two layers. You can see the fascia covering the posterior wall. The veins of the vagina lie between. Remember good old days when you put your finger there and it bled because you went between the fascia and the posterior vaginal wall. The paravesical space, I have already shown you. The paravesical space is something which is very, very simple. Once you see, that's the paravesical space, and the base of the paravesical space is formed by the levator ani muscle. The prevesical space is required for Birch repair. You have to identify the two median umbilical ligaments, which are nothing but the obliterated hypogastric artery. That's the internal iliac artery, anterior division. It ends, it is called as a median umbilical ligament. Again, fat belongs to the bladder. When you want to go into the prevesical space, remain above the fat and you can enter. See again, look at the fat, remain above the fat, and then you can go inside. So simple rules of dissection, you can see that. That's the area which you can see, and you are now going into the pubic symphysis area, which is the area for your Birch repair. The bladder dissection, I've already shown you, just to give you this idea that the bladder remains anterior to the uterine artery. You see the clip. Do not push below the uterine artery. The bladder lies anterior to the uterine artery. The fat belongs to the bladder, and that's how you can see. Remain below the fat and just push. Remain below the fat and just push. Simple techniques that you can have it. I'm not going to take you about the applied anatomy. Lastly, the Yabuki space. A lot of people ask about this. This is a Japanese surgeon which showed the fourth space. That is the space which is medial to the ureter, and that's the final space through which the nerve goes towards the bladder and the vagina. It is characterized by the presence of inferior vesical vein. So if you take, and the deep uterine vein, if you take the deep uterine vein medial to the ureter, the nerve automatically gets completely preserved. Simple rules, don't try to see the nerve. Take the uterine vein medial to the ureter and the nerve will be completely. So with this basic knowledge of anatomy, we have evolved into the parametrium. This is very important even if you're not doing a cancer cervix. This is the parametrium which is invariably involved when you want to do stage 4 endo. You can see the posterior parametrium, which is the uterosacral, the lateral parametrium, which is the Mackenrod, and the anterior parametrium, which is characterized by the presence of inferior vesical vein. The characteristic of female anatomy is the inferior vesical vein drains through the deep uterine vein and does not drain directly into the internal iliac vein. So you can see this is here, it will drain directly into this area. And when you want to dissect this, the superiorly, this is the cervicovesical ligament, commonly called as the ureteric tunnel. It has two veins which drain from the bladder into the deep uterine vein. So always put two small clips, because if you put the clips, then only you can see how the ureter can get easily lateralized. This is where the bleeding normally takes place, and if you don't do this, then a small strands of endopelvic fascia. This is also called as infraureteral parametrium or the anterior parametrium. So this is what you can see. This again, just to give you, this is a this is the cut end of the uterine artery. Hold the cut end of the uterine artery, put two clips over there. This is the anterior cervicovesical ligament, and just cut it, and you see the anterior parametrium getting exposed, and this anterior parametrium will allow you, and this is one of the reasons for LACC trial, and we have already published this, and these are the key steps. We just got the 5th Golden Telescopic Award for understanding the anterior parametrium in preventing local and pelvic recurrences. We just published this also. It's very important. Anatomical description of the anterior parametrium. This is what we published now. An answer, probable answer to this. Vascular anatomy, what is more important, all of you have to understand, none of the big vessels have any tributaries, any branches on the anterior side. Look from the aorta, go up to the common iliac, go up to the external iliac, no branches. So if you understand this, and also no branches or the tributaries on the external iliac vein, then the simplest way is to remain parallel to the vessels to do this dissection. Because there are no tributaries, no branches, just remain using the anatomy, just remain, look at that, there is a fascia which covers the vein. Anatomically, there is always a fascia which covers the vein. Always remain parallel. This is a life lesson also, remain parallel to your spouse, never perpendicular. It's always good. It helps your life, okay? So this is how you can do this. You can do it with simple kind of entire thing, and you can see that it is just remaining parallel and parallel. You see, you don't use any kind of dissective energy source. There is a fascia, you can see, which is covering the external iliac vein. Simply just go and remain parallel. and everything just comes out so beautifully that it will be out. This is how you should be doing the nodal dissection, and this is parallel and parallel. Again, you go there, remain parallel, and you will see now the circumflex iliac vein coming in. That's the part of the corona mortis. Again, remain parallel, and the entire nodes will come out. So then if you understand this anatomy, when you are in difficult situation, now look at this situation. We had a post chemotherapy, post radiation patient who had just the nodal mass over there. And when you are trying to take out, we had a little bit of bleeding, but we know that there are no tributaries on the anterior side. So there was, as we were going around, there was a bleeding. So I can just put a small clip. Don't try to do this. This was a mistake. This was my fellow first doing it. He called me, but I told him that this is what we should do. We just put the clips. We knew that there is only lateral bleeding. There are no tributaries. And once we finished this, so we took out the node, kept on applying tributaries to the lateral side. First take out the node, make a space for yourself. This is a node which was very, very badly stuck. And once you have inside, you know that it is there. We took out the clips and then took a suture. So we overcame this situation just because we understood the anatomy, which is very, very important. Now, the internal iliac vessels, which is the most important thing, the anterior division. The first branch is the uterine artery, and you can see the first branch is given almost 6 centimeters after the bifurcation. How do you use this knowledge of anatomy? You can see this is a long length of the anterior division available for ligation. So if you in PPH you want to ligate the internal iliac artery, don't go close to the bifurcation, because this is an artery which is going there and you have enough length of the internal iliac artery. Then the artery also has a long length. It is 7 centimeters before it reaches the entire uterus. So in case you are doing a hysterectomy, understand that the artery goes above and the vein goes below. So when you want to have this kind of large fibroids, and when you want to do this, then people always, when you want to do this, people always say, where do you use this? So you can use, this is a large fibroid. You know that you're not going to approach this area. You can remain parallel, go externally, use this knowledge, go there and then dissect the entire ureter. So the uterus is pushed on the medial side. You go there, try and find the uterine. You know that's the only structure in the pararectal space which crosses transversely. Just put a clip. This is how you can apply the anatomy to do this. Now, this is the uterine artery. When we started doing uterine transplant, we realized that what has been described in Gray's anatomy, that there are just 2 branches to the uterine artery. We realized that there are 8 branches to the uterine artery, and these branches have to be individually ligated. This is again a publication coming in JMIC, understanding the gamut of uterine artery, because that's the artery which you have to dissect, but that's not important for a normal gynecologist. You can see the idea of uterine artery cross anterior, the vein goes below the ureter. Why do you want to know this? Because if there is bleeding, you have to understand whether it is arterial or venous bleeding. If it is an arterial bleeding, it is anterior to the ureter, depress the ureter. If it's a venous bleeding, lift up the ureter, because you know that it's going to come from below. And this is the most important thing, that we understood anatomy, and that led us to using the ovarian vein and not the uterine vein for the uterine transplant, because of understanding this. What about corona mortis? You can see the only branch or the tributary of the external iliac vein is the circumflex iliac vein, which goes and joins the obturator vein down. It is called as corona mortis because the obturator vein is a tributary of internal iliac vein, and the external iliac vein tributary is the circumflex iliac. It is more for the general surgeons who do hernia surgeries, because if you cause a bleeding there is a bleeding from both the systems. This is the obturator artery, which is always lying below the nerve. If you know that the vessels lie below the nerve, always remain superficial to the nerves when you want to do a complete dissection. What about the ureter? Our friend, this is most important thing, everybody wants to know about it. Ureter carries its own mesentery. you can say, and this mesentery is the most important thing. So you can actually do a complete dissection of the ureter from the sacral promontory up to the uretrovesical junction. You wonder, how does the vascular supply remain? Because the ureter is supplied by the branches of infundibulopelvic ligament or ovarian ligament right at the level of the kidney. It carries its own mesentery downwards. The mesentery is always on the medial side. It is like an hamburger. You can see that the ureter lies anteriorly, there is an artery, posteriorly there is a vein, and it is the mesentery which it carries along it. If you understand it, it's good. Dissection of the ureter should therefore remain always on the anterior and the lateral side. Because the mesentery is on the medial side, simple concepts of anatomy, understand this. No use of energy sources, and ureter always, if you cannot find the ureter, it is the most important thing. Come to the sacral promontory. Remember my words. Just whenever you are in trouble, go to the most virgin area, and that's where you are going to find. Where is the ureter? If you cannot trace the ureter, just antevert the uterus, because the ureter always lies at the base of the uterosacral. It will never go up to the apex of the uterosacral. In case you don't want to dissect the ureter, then just go and remain. The ureter lies at 2.5 centimeters away from the base of the uterosacral. So Teeland has written at no point of time the ureter is less than 1.5 centimeter. A complete wrong statement, and this is the most important thing you have to understand. Antevert the uterus, the ureter is always at the base, and just go ahead and do the dissection. What about the tunnel? Don't try to dissect the tunnel with the energy sources, because it is the misnomer. There is no ureteric tunnel. The tunnel doesn't belong to the ureter. It is the cervicovesical ligament and carries two veins from the bladder always and always. That's where the bleeding took place when you dissected the ureter. You tried to coagulate and you led into the ureteric fistulas. Understand the anatomy. Lastly, the neuroanatomy. These are the four nerves which are very, very critical. The genitofemoral nerve, very easily seen. Then of course the obturator nerve, and of course the hypogastric nerve. So you can see this is the obturator nerve. The obturator nerve lies in the bifurcation between the external and internal. What is the significance of the nerve is that the arteries and the veins lie below the nerve, and therefore when you do the dissection, always remain superficial to the ureter. The genitofemoral nerve lies lateral to the external. But what is most important is there is a nerve which lies below the obturator nerve, which is the sacral nerve. But do you know what is the most important thing of three nerves? All the three nerves have the same root value, L4-5. Obturator nerve, L4-5, genitofemoral nerve, L4-5, femoral nerve. Also that the sciatic nerve also has L4-5 joined by S2-3-4, and that's when it becomes a largest nerve of the body. So this is the obturator nerve, you can see, and then you can see the sciatic nerve. All the nerves arise from the postganglionic fibers of L4-5. The root value remains the same. So do not go up below the bifurcation of the vessels. That's where the plexus lies. You will damage L4-5, finally damaging even the sciatic nerve at this level. So this is all the nerves you can see in one video, and this is, I don't think it is working. Anyway, the next nerve is, of course, this is the hypogastric nerve, which always lies on the posterolateral side of the ureter. This is posterolateral in the rectum. Then it is joined by the S2-3-4 nerves when you have this neurovascular bundle, also called as the Van Frankerhauser's plexus or the inferior hypogastric nerve. So this is important. Significance of this nerve is you have to preserve the inferior hypogastric plexus and preserve the pelvic splanchnic nerve, because it helps you for early recovery of the bladder, rectum, and most importantly in endometriosis. The nerve is very important for vaginal lubrication, because you do fertility preservation surgeries, and this is very important. So start by doing what is necessary. What is necessary? Total laparoscopic hysterectomy. Understand the anatomy. And then as you start talking to yourself in the operation theatre, one day you will find that you are doing a better thing than what you are supposed to do. So nerve sparing radical hysterectomy is something which is the most important thing. Finally, I would like to show you, if you remain to the principles of anatomy, even if you have, this is the anatomy, you can see we are doing the para-aortic dissection. There were large nodes. You know that there are no tributaries on the inferior vena cava. You can see a large node. What am I doing? I am just remaining parallel and parallel. This is the most important thing that you have to understand. So even if you have a big nodes, these are the very big nodes which are there. You can see just remaining parallel to the structures. This is how you can see that there are no tributaries, no branches, and you can clear the entire area very, very nicely by just remaining parallel without using energy sources. So this is, we should not be fearing. It will really require a lot of strain to have any damage to the common iliac or the vena cava. So just remain parallel and all the nodes will come out. This is the roadmap of pelvis. You can see that the ureter is the most medial structure. If you remain medial to the ureter, you don't damage the internal iliac. If you remain medial to the internal iliac, you don't damage the obturator nerve and the external iliac nerve. So this is how it looks like at the end of the dissection, right from genitofemoral nerve. The most lateral structure is the external iliac artery and the vein. And if you remain and understand this anatomy, now this is what we published. A lot of things which were mentioned in gray, we challenged them. We published this in the International Journal of Obstetrics, that is the PGOS International Journal. You can go through this article, Surgical Pelvic Anatomy in Gynae-Oncology, and in Journal of Minimally Invasive Surgery, understanding the pelvic anatomy and the innovations which are there. Till now, 90 citations of all the things that I have said that in the lecture, and the recent article Avascular Spaces has very clearly said that Kuntambecker et al. Described remaining parallel to the major vessels avoids damage to the vessels, completely vindicating whatever we have been saying from 2005. This is the latest Avascular Spaces of the female pelvis, clinical applications in obstetric and gynecology. So take home message, uterine or cervical pathologies do not reach the sacral promontory. Whenever you're in trouble, start your dissection at sacral promontory. Always remain parallel. Identify the fascias, because all the fascias, the veins lie below the fascias. Remaining medial to the ureter will avoid damage to the internal iliac artery. Fat belongs to the bladder, fat belongs to the rectum. Ureter lies in the fork between the artery anterior and vein below. Ureter carries its own mesentery. But the last thing is there are no variations. There are females from various areas. So, but believe me, I have operated in all the continents. The female pelvic anatomy remains constant. So when somebody comes and tells me that it was a completely distorted anatomy and I had a tough time, I always tell him, you have a distorted mindset. The anatomy is constant. Your mind is not working in the right direction. And that is what is more important. So life is a process of evolution, and anyone who thinks that the current world order is okay, evolution is all about. So laparoscopic era is changing. We are understanding the anatomy, but what matters is the skill, the knowledge about anatomy, predictive anatomy, precision. So when you are a surgeon ready with your armor, you have to understand anatomy. No matter how big you become, anatomy, and nothing else but anatomy. And there are always, I always see that if you want to, of course, succeed in life, there are 3 C's. Compassion. As doctors, we are very compassionate. We are courageous. As she gave the first lecture, you're courageous in operating every day. But I think if you want to be really successful, you require a little bit of craziness, which I have in plenty. Thank you very much, ladies and gentlemen. And Kavita, I have given 1 hour, 1 minute and 33 minutes, 33 seconds. Yes. Thank you very much.